Good afternoon, everyone. I don't have any financial interest in this presentation.
Ma'am, closer to the mic.
In the past 2 decades, there is a multifold increase in the survival of children, preterm children, because of the better care. And this results in an enormous increase in children requiring intervention for ROP. As a pediatric ophthalmologist, we are worried about the long-term sequelae if it goes unnoticed, will end up in preventable blindness. So we wanted to study the prevalence and association of refractive error and strabismus with children in ROP at a much earlier age group at various intervals, and to compare it with the regressed ROP and the children who took treatment. Around 96 children were included in the study. All children at 6 months of age diagnosed with ROP, whose parents were willing to participate, were included in the study. And children with stage 4 and 5 were excluded. Children with other ocular disorders and who had ocular surgery and major systemic illness and children with CP were excluded from the study. They were divided into 4 groups, depends on if they have spontaneous regression or what type of treatment they have taken. Patient-related history was taken from the parents, and information about ROP and the treatment was obtained from the patient record. Each visit, visual acuity, refraction, and cycloplegic refraction were examined using an age-appropriate method. Anterior segment evaluation and orthoptic evaluation was done by the pediatric ophthalmologist, and the retina evaluation was done by the retina surgeon. Coming to the results, children with stage 1 was 34.4%, and children with stage 2 was 33.3%, and children in stage 3 was 27.1%. 2 children had cicatricial ROP, and 3.1% of the children had AP ROP. And most of the children had laser treatment. 34% of children had no treatment, and they regressed spontaneously, and 6.3% of children had only injection. Children who didn't respond to injection or who had recurrence after injection were given additional laser. So it was observed the prevalence of myopia increased over time from 35.6% at 6 months of age to 41.8% at 24 months. Like many other studies, we also saw the incremental increase in the magnitude of myopia. The myopia was more prevalent in zone 1 and zone 2 posterior compared to zone 3. And coming to the stage of ROP, stage 3 ROP and who had plus disease had more of myopia and hypermetropia compared to stage 1, 2 and who didn't have plus disease. Coming to the treatment part, it was so obvious children who had injection and additional laser had the maximum prevalence of myopia and high myopia, and it was least with the children who had only injections. It was in correlation with the BEAT study. Most of the children had with the rule astigmatism. Children with plus disease had maximum of astigmatism, and children with injection and laser group had maximum astigmatism, but it was not statistically significant. Coming to the mean spherical equivalent, you can see there is an obvious significant difference over the visits. 6 children had strabismus, 4 of them had esotropia, and 2 of them had exotropia, but we couldn't find any correlation between zones or stages or treatment. So prevalence of myopia increased over the time. Incidence of developing myopia varied among the treatment groups. There was no association with other factors with squint or anisometropia, and the magnitude of astigmatism remained fairly constant over the period. From the pediatric ophthalmologist's perspective, all of us understand the difficulty in treating the preterm children, making them survive, treating them for retinal problems, and leaving them blind just because we undiagnose or delay the diagnosis of refractive error. So I want to insist the proper protocol, which should start as early as 6 months of age and should be followed up periodically, whether they belong to the observation group or if they have taken treatment. That doesn't matter, because 30% children in observation group also have refractive error. So strict protocol should be followed even after their retinal maturity completes. Thank you.
Where this study was conducted, center, secondary or tertiary somewhere, or like
Tertiary care center.
tertiary care, and how many investigators were there? Investigators. Yeah, you have collected hospital data. How did you collect your data?
From our hospital EMRs.
EMR. Okay,
EMR.
so this is a retrospective.
Yes, sir.
Okay.
Sir, this was a prospective observational study.
Okay.
Only the treatment, retinal treatment part, we collected from the EMR, but progressively we followed the patients after 6 months of age.
No, one thing is like again, Amir is there. After laser group, myopia is going to increase. So something after hitting laser is going in vitreous. What is the reason? That could you try to find it out?
Sir,
Just
like
you are yeah.
it is like many studies quote that because of the anatomical changes and the destructive part of the laser,
Yeah.
which causes it, but we didn't really go into the details of how it is causing.
Still we didn't know that. Okay.